just with a brief review of your bony anatomy, looking at the tibiofemoral and patellofemoral joints. Okay? So if you are looking at this picture right here, we are in the middle of the knee. Okay? So this is an inferior to superior view of the femur. This is a superior to inferior view of the tibia. Okay? Does that make sense? So we're right in the middle. It's like it's been broken right open. Okay? So if we start on the femoral surface first, you can see here we have the medial condyle and the lateral condyle. Okay? If you look at these little dotted lines, you can see that the medial condyle is bigger than the lateral condyle. Okay? Let's see. You can also see how the patella sits in the groove of the femur, as well as your attachment points for the ACL and the PCL. So we'll go over those today as well.
So you said the top is the femur?
This whole bone is the femur.
Okay.
This whole bone is the tibia.
Okay.
Okay, so we're looking up at the femur.
Oh, I see it
And
now.
down
Sorry.
at the tibia.
Okay.
Okay. All right, let's see. Okay, so like I said, you can also see your kneecap and how that sits in the groove. Okay, this is obviously going to be a sesamoid bone, and that is going to sit underneath your quadricep tendon. Okay, so quadricep tendon is going to go right over top of it, and then down into the tibia. And again, we'll talk a little bit more about that part later. Okay, so coming down here, looking at the tibia. So again, this is a superior view. We're looking down at the top surface of the tibia. So here you have the medial and the lateral tibial condyles, okay? And this entire top surface of the tibia are the medial and the lateral tibial plateaus, okay? So on top of the plateaus, you have your menisci. So you have a lateral meniscus that sits on the lateral side and a medial meniscus that sits on the medial side, okay? And again, you can see there where the ACL sits and where the PCL sits in relation to those bony surfaces. Okay. In this picture, you can see where the fibula is sitting. So that's going to be lateral and slightly posterior to the tibia. Okay. Make sure you know that your tibiofemoral joint, that is your actual knee joint, versus the patellofemoral joint is just the articulation between the patella and the femur. Right here, the articulation between the fibula and the tibia is going to be, well, what's that called? Articulation between the tibia and the fibula right here. Anybody? So you have to guess. So this is going to be the proximal tibiofibular joint. Okay, there's also a distal at the ankle. Okay, but that is not technically a part of the knee joint. So if someone is talking about the knee is just the tibiofemoral joint. Okay. All right, so tibiofemoral joint. This is going to be the largest joint in the body. Okay, it also has the largest capsule in the body. It is classified as a synovial hinge joint, but it is not technically a true hinge joint. Does anybody know why?
Because it's
Slightly.
What kind of rotation does it have?
Is it the one that like you have to do?
It's like the screw home mechanism.
Yes. What did you say?
Is it the one that you have to do manually?
Yes. So at the knee, you have an accessory motion for tibial internal rotation and tibial external rotation. So this is a part of the screw home mechanism, which we'll talk about in a few slides, but that is why this is not technically a true hinge joint, because it has the flexion extension, but it also has a tibial internal and external rotation. Okay, so again, that's not just a standard osteokinematic motion. You cannot actively make that happen. It is just going to occur as an accessory movement. Okay, so that brings us to our patellofemoral joint here. So again, this is just referring to the articulation between the patella and the femur. Okay, so your main function of the patella is to to increase the mechanical advantage of the quadricep. Right? So, by doing that, or in order to do that, you're basically increasing the moment arm. Who remembers what the moment arm is? Pull that knowledge out from way back when.
You said that's a lever?
The actual moment arm. What's the definition for a moment arm?
Is it the distance between the axis and the force?
So it is the perpendicular distance between the muscle's line of action and the actual center of a joint. Okay? So this space right here, here's the center of our joint. There's the tendon technically. That distance is increased by the placement of the patella. Okay? With that increase, the quadricep is now able to exert more force.
Can you say that one more time,
The whole
please?
thing. Okay, so we we have the moment arm. The moment arm is the perpendicular distance between the muscle's line of action and the center of the joint. Okay, so by putting the patella here, between the patellar tendon and the femur, you have now increased the moment arm. By increasing the moment arm, the quadricep is now able to exert more force. Everybody good? All right, so in terms of your osteokinematics, this is going to be really easy for this joint. All we have is knee flexion and knee extension. So for knee flexion, your norm there is 135 degrees, and that is going to have a soft end feel. Okay, that's going to occur because of that, muscle belly contact or soft tissue contact between the calf and the back of the thigh. Okay, for knee extension, your norm there is 0 degrees. So it should basically just be a straight line. And there you're going to have a firm end feel because of ligamentous constriction. Okay, it is common to see about 5 to 10 degrees of hyperextension at the knee, but in terms of your board prep book norm, it is 0. Okay. All right, in terms of your open packed position, write this down because I don't have it on the slide. Open packed position is when the knee is flexed to 25 degrees. Okay, so that's where you would have the most available joint play. That's where you would perform your knee mobilizations.
Is it just 25 degrees?
Yes, a flexion.
And that's the tibial femur.
Correct. So that we are just talking about the knee, so this is just the tibiofemoral joint. Okay? For your closed pack position, that is going to be full knee extension with tibial external rotation.
It is on 360.
The open pack, closed pack, 316 is the
External or internal?
external. External for closed pack. Okay? Your capsular pattern here, flexion greater than extension.
Is that always the case? Because so far, I think flexion has always been greater than extension in all the things we've.
I've never thought about it like that, so I will have to
Okay.
confirm or
Okay.
I say yes or no.
Okay. Yeah.
Okay, everybody good with those? Okay, so for your arthrokinematics, your femoral condyles are going to be your convex surface. The tibial condyles are going to be the concave surface. Okay? You are going to have both a roll and a glide when it comes to the tibiofemoral joint. Okay? The same rules of your convex concave rule as we previously talked about. Okay? So this one should be pretty easy, straightforward in terms of the rule. Okay? So if we are moving in open chain, which bone is moving on which bone?
tibia is.
Correct, so your tibia is going to move on the femur. So does that mean it is convex on concave or concave on convex? Concave on convex in open chain. So what does that mean?
Same direction.
Same direction of the glide.
Okay, so roll and glide are going to occur in the same direction. It's going to be the same direction as the distal end of the moving bone. Okay, so if we were to go into, let's say knee extension, okay? In knee extension, that means my tibia is going to be moving anteriorly. Okay, so your roll and your glide are also going to be occurring anteriorly. Okay, if I needed to work on knee flexion, in knee flexion, the tibia is going to move posteriorly, meaning your roll and your glide would occur posteriorly. Any questions there? Okay, not getting much feedback, so let's do this. Partner up, say it out loud. Just like 3 minutes, just run through it, make sure. Open chain extension. When you go into full end grade knee extension, about the last 5 degrees, it becomes very evident, last 5 to 15 technically, okay, that the tibia is going to externally rotate, okay? So you get the tibial external rotation at end range knee extension in open chain, okay? That basically helps to lock the knee joint, okay? That part of this is what is called the screw home mechanism, okay? Now, in order to unlock it, the popliteus is the muscle that unlocks the knee, okay? For that to happen, the tibia has to first internally rotate before it is able to go into knee flexion. Okay, so it's coming out of that externally rotated position. It is internally rotating in order to flex. Okay, so again, your screw home mechanism, open chain knee extension, tibial external rotation. In order to return to flexion, it has to unlock and go into tibial internal rotation. Okay, a lot of this is due just to the natural bony anatomy. Okay, again, these are not independent motions, these are accessory motions. So they are occurring as a result of the knee extension or knee flexion. Okay. This is really important clinically, okay? After any type of knee surgery, the biggest thing that you guys need to focus on is restoring knee extension range of motion, okay? That is the most important thing that people need for walking, and it is usually the hardest thing to get back, okay? If you are just mobilizing straight into knee extension, you are not going to get them back to their full range of motion unless you also work on the tibial external rotation on top. Okay, so I'll teach you guys how to do that in the future, but you have to understand this underlying concept first. Okay. All right, we have another angle at the knee. This one is called the Q angle, okay, or the patellofemoral angle. You'll hear it referred to as both. But this is basically the angle that sits in between the quadricep muscle, so the line of the quad, and the line of the patellar tendon. Okay, so you can determine it by drawing a line from the ASIS and go all the way down, just the line of the femur, to the midpoint of the patella. Okay, and then your second line, you're going to draw it up from the tibial tuberosity through that midpoint of the patella. And then you'll see how those two lines intersect, and this is the angle that you would measure. Okay, so your norm here is 13 to 19 degrees. This angle is going to tend to be wider in females because we'll have wider hips than males. Okay, and this is in reality reality, probably not something that you'll actually do in clinic, but understand that an increase or abnormal Q angle is associated with a lot of patellofemoral dysfunction or a lot of patellofemoral conditions.
Stress.
Yeah, exactly. Okay, we also have abnormal patellar positioning, okay? So if you look at the patella, this is your normal picture right in the middle here. So it's sitting right at the femur. And the length of the patella is typically a 1-to-1 ratio with the length of the patellar tendon, okay? So from here to here on the patella, that's how long the patellar tendon should be underneath it. Patellar tendon connects from the patella to the tibial tuberosity. Okay, so we have an abnormally high patella position, which is called patella alta, and an abnormally low patella position, which is called patella baja. Okay, I remember then that they're in alphabetical order. Okay, A is higher, B is lower. Easy enough to remember that. Okay, so patella alta is higher, patella baja is lower. So if you look at the position of the patella, you can see here that the length of the patellar tendon is going to have to be much longer if you have a high riding patella. Okay, versus patella baja, your patellar tendon length is going to be much shorter. Okay, so with an abnormally long patellar tendon, in this patella alta positioning, they're more likely going to be prone to instability type issues. Okay, they're going to be more hyperflexible. Versus patella baja, since it's so small, these people are more likely to have restricted range of motion. Any questions on that?
Can you repeat the Baja one again?
So patella baja, your patellar tendon length is going to be much shorter. So those individuals are going to be more prone to range of motion deficits. Okay, so next we're going to consider the compressive forces that are occurring at the knee. So when you are sitting with your knee in full extension, this is going to be the open pack position of the patellofemoral joint. Okay, so in that position, you have very minimal contact between the patella and the femur. Okay, just kind of that inferior pole of the patella is in contact with the femur, very little. Okay, so your patella has not yet entered this intercondylar groove. Okay, so here you have minimal joint congruency. Like I said, that's more the open pack position. So full knee extension is where you would do your patella mobilizations because you don't have that congruency. Okay, same thing here. Those are very important to a post-op knee patient. Okay, the patella has to move appropriately, just as importantly as the rest of the actual knee joint. Okay, so again, full knee extension, that's where you're going to do your patella mobilization. Okay, open pack position, patella is very mobile there. Okay, now as you move deeper into knee flexion, the patella is going to sink deeper into this groove. Okay, as it does that, this is becoming more of a closed pack position. You're increasing stability in this position, and you're also going to increase the compressive forces in this position. Okay? So you can see as the knee flexion range of motion changes, this is the area on the patella that would be in contact. Okay? So these are kind of the highlights to pull from this picture. I know that can kind of get a little confusing the first time that you're seeing it. So just make sure you understand knee extension, open packed, least amount of congruency. Okay? As you go deeper into flexion, you're increasing decreasing the amount of contact, you're increasing the compressive forces. Okay. So in, more end range knee flexion, it's going to be much harder to mobilize the patella as it would be if you were in knee extension. Okay.
Quick question.
Yeah.
Maybe we'll get to this later. Chondromalacia and the patella not riding in the middle, is that related not only to that acute ankle?
Yep.
But also, can it be muscle imbalance as well?
Yes, it could be any of those things.
And there's ways to make the patella do what it should if it's muscular?
If it's muscular,
Okay.
yes, but if you have, like, if you're looking at the patella alta, where you have over-lengthened tendon, there's nothing that you're gonna be able to do tendon-wise at that point. You can still work to stabilize all of the surrounding musculature and give the knee more support, but you're not gonna be able to do it.
It's riding high, but it's not, more lateral or medial, that's a different thing.
Correct.
Okay.
Yeah, this is just high or low. Okay. All right, so that also brings us into this lower extremity malalignment, where you're gonna have more of the frontal plane deformities. Okay, so your big positions here are called varus and valgus. Okay, you'll also hear them referred to as varum and valgum. Okay, so genu valgum, that's this one right here. This is going to be more your knock knee position. Okay, I always remembered it by valgum. You have gum stuck between your knees. Okay, sticking together. Easy way to remember that. Okay, so in this position, you can see that the femurs are typically angled more into adduction. You might also have, an internal rotation of the femur as well, but at least the adduction. Knees are close together, and then the feet are farther apart. Okay, versus your varus or varum positioning, this is going to be more your bow leg position. Okay, so your ankles are positioned more medial in comparison to the knees. Okay, so this would be normal right here where you just have a straight line. Okay, so in that position, your weight-bearing forces are going to pass directly through the middle of the joint. Okay, and that's ideally what you would want. With genu varus, that weight-bearing line is going to shift medial to the knee. Okay, so you're going to get more compressive forces on the medial aspect of the knee joint. Okay, versus your valgus positioning, that line has now shifted to the outside of the knee, so you're going to get more of your compressive forces on the lateral aspect of it.
So can this also relate to the coxa valga and vera also with like the angle of inclination and all that?
Yes.
Okay.
Yeah, so you can have something that's occurring at the hip that's going to affect what is occurring at the knee. And a lot of times you're gonna see, okay, this is primarily a hip problem, but now they're doing something compensatory at the knee to try to get them back into a straight line. So oftentimes we will see things kind of happening simultaneously.
Trickle down more or trickle up more?
Chicken or the egg?
Okay.
I would say, in my clinical experience, I think it's more often the underlying issue is at the hip, and it goes down to the
Is this,
and then the foot. Yep.
this could, the issue could be acquired or just?
Yes, it can be acquired.
Yeah, yes.
And once it is acquired, it will worsen over time because of these lines of forces. So once you have, some sort of dysfunction where, you're going into this position, especially like young teenage girls where they're really hypermobile, they might start out here where they're still really flexible and they could get themselves out of that position. But over time, it's going to become more permanent if they're not getting themselves out of that position. And then once you start having the bony breakdown, then there's not much you can do. It's just going to continue to worsen and worsen and worsen.
So this isn't due to coxavir, coxvalga, the ankle of inflammation necessarily, it's just one
It
thing.
can be. It can be. So they could be interrelated conditions, or they could be completely separate conditions. Okay? Okay, we also have, and with that, like, these are not diagnoses, okay? These are just postural observations that you guys are making that you could document. Okay, does that make sense? Okay.
Is varus more common in men? I feel like
I
I've
would
seen
say,
a lot more.
like, very, very generally, I would say varus is more common in men, valgus is more common in females. But you will see both in both genders. Okay, genu rubicundum, this is basically excessive hyperextension of the knee. Okay, so when somebody stands up straight, you can see kind of this backward angle right at the back of the knee. Okay. And then last one is tibial torsion, okay? So we already talked about how tibial internal rotation, external rotation are accessory motions. So tibial torsion is going to be, a structural abnormality. Again, this more than likely is present as a compensatory pattern for something happening at the knee or something happening at the hip, okay? So, for example, you could have, an issue at the hip where the hip is sitting in more internal rotation, and then all the way down the chain, well, now your foot is turning inward as well, okay? Or it could be backwards. Okay, well, the hip is really sitting in external rotation, so the tibia is going to try to excessively internally rotate just to get the leg to sit in a straight line. Okay, so again, these are more compensatory patterns at the lower end of the leg for something going on up the chain. Okay, so in general, tibial internal rotation, you're going to have more of a toe in position. Tibial external rotation, you're going to have a toe out position. Okay, you need to know which muscles contribute to those things. Okay, so for tibial internal rotation, that's going to be controlled by semitendinosus, semimembranosus, gracilis, sartorius, and popliteus. Tibial external rotation is just biceps femoris. All right, let's get through this little section, then we'll take a small break. Okay. All right, so moving on to some of your soft tissue structures here. The knee, like we said, it has a joint capsule. Okay, this is the largest joint capsule in the body. It has a very tough membrane that is going to be made of the ligamentous tissue as well as the synovial membrane. Okay, we mentioned the menisci earlier. So you have a medial meniscus and a lateral meniscus that sit right on top of the tibial plateaus. Okay, so these are these little kind of half moon shaped, they're fibrocartilaginous discs. Okay, so in general, your tibial plateaus, they're super flat structures. All right, so when you put these menisci on them, then it changes the surface to be a little bit more concave. Okay. Both of these structures are going to be thicker laterally. Okay, and then they're going to be thinner, more medial. So they are able, with this structure, they're able to deepen the surface of the joint. with their ability to deepen the surface of the joint. They're adding that concavity. This is overall going to help to improve the congruency of the tibiofemoral joint as a whole. Okay, these are very important because they are shock absorbers. Okay, they're able to help distribute the forces that go through the knee. And then, of course, they're gonna reduce the friction between the femur and the tibia. Okay? One really important thing to note here is the blood supply to the meniscus. Okay? So, only the outer third of the meniscus gets blood supply. Okay? So that is gonna be the portion that's colored red here. Okay? The white zone of the meniscus does not get blood supply. And that is going to influence the type of surgery that somebody was to get if they had a meniscal injury. So, if they had a tear in this red zone, they're more likely to receive a meniscal repair, where they go in, they stitch it up, because it will heal. Okay, that is a more difficult surgery to recover from. They're usually non-weight bearing for several weeks on crutches while it heals. Okay, the other option, if you had a tear in this white zone, we know there's not good blood supply there, it's not gonna heal on its own, and it's not gonna heal if you do surgery there. Okay, because it's not gonna get any nutrients. So what they're gonna do is they're gonna come in and do a meniscectomy, where they go and basically just cut out that little area where the tear is. Okay, looks like little nail clippers. They just go in and snip it out.
And when it flaps sometimes and when you bend on itself.
Yes, that can occur as well. Okay, so, but that's why that blood supply is important.
For the second version, is there like a extended recovery something else too?
No, that's really quick, really quick. So after a meniscectomy, there's no weight bearing restrictions. It's just as tolerable. You try to get them back as quickly as possible. Okay, usually depending on their activity level, you could be back to running in 8 weeks.
There's nothing synthetic, right, that they can put in to have a little shock absorber?
There are, I can't remember exactly what it's called, but they are starting to play with like a meniscal transplant. I think I've seen one, not a common surgery yet, but it is heading in that direction. Okay. All right, we also have knee plica. So you have 4 of these in your knee, and normally these are pretty harmless, irrelevant structures, but sometimes they can kind of get caught in the knee and get inflamed and activated, okay? That would just lead to pain, potential locking of the knee. But these are basically just folds in the capsule, okay? So, know that they exist. Don't spend a lot of time on this for now. Not a structure I'm really worried about you guys knowing. Just know that you got 4 of them. All right, for the bursa, the knee has a ton of different bursa, okay? It has about 13 of them that surround the entire knee joint, okay? So we know, what is a bursa? That hurts and stuff. A small fluid-filled sac, and what is its job? To reduce friction. So remember, at the knee, the majority of the muscles that transverse the knee are occurring in a vertical fashion, okay? So because of this, it needs a lot of support from the bursa in order to help reduce the rubbing of those tendons or those muscles against the bone. Okay, so they're protective in nature. Again, overall goal here is to reduce the friction.
Can you say that again about the vertical?
So at the knee, the majority of your muscles are crossing the knee in a vertical fashion. So because of that, they need that extra little support from the bursa to prevent the rubbing of the muscle or the tendon against the bone. Okay, so overall, this is just gonna help things to move a little bit more smoothly. Okay, so the bursa, the knee, the bursa, the tendon, the tendon, the bone. Okay, so overall, this is just gonna help things to move a little bit more smoothly. Okay, so overall, this is just gonna help things to move a little bit more smoothly. Okay, so overall, this is just gonna help things to move a little bit more smoothly. Okay, so overall, this is just gonna help things to move a little bit more smoothly. Okay, so overall, this is just gonna help things to move a little bit more smoothly. Okay, so overall, this is just gonna help things to move a little bit more smoothly. Okay, so overall, this is just gonna help things to move a little bit more smoothly. Okay, so overall, this is just gonna help things to move a little bit more smoothly. Okay, so overall, this is just gonna help things to move a little bit more smoothly. Okay, so overall, this is just gonna help things to move a little bit more smoothly. Okay, so overall, this is just gonna help things to move a little bit more smoothly. Okay, so overall, this this, when the muscles of the leg get tight or overused, those bursa are going to become inflamed and aggravated. Okay, so it's pretty easy to get a bursitis at the knee because of overuse. Okay, so your goal in those situations would be to address any muscular imbalances that were present. Okay, the three big ones that I want you guys to know occur at the patella. Okay, so you have a suprapatellar bursa, a prepatellar bursa, and an infrapatellar bursa. Okay, your suprapatellar bursa, just like the name implies, is going to sit superior to the patella. Okay, this is typically going to get aggravated when the quadricep is tight or overused. Okay, especially jumping activities.
Which muscle is it?
Quadricep. Okay, your prepatellar bursa is going to sit anterior to the patella. Okay, so it will be just underneath the skin. This is going to get aggravated with excessive kneeling. Okay, this type of bursitis is also called housemaid's knee.
Also houseman's knee.
Yes.
Going forward.
Good correction. Okay, last one we have here is the infrapatellar bursa. Okay, so that's going to sit inferior to the patella. And again, that's going to be aggravated with an overused or tight quadricep. Okay, you're going to see this one more with activities like running, kicking, jumping, those types of things. You can also see right here, I know it's not listed, but the Pezan-Sarai bursa. Okay, what's the Pezan-Sarai? What are the sergeant muscles?
Question.
How about one person tell me?
Sarah.
Gracilis, sartorius, and semitendinosus.
Sartorius, gracilis, semitendinosus, sergeant muscles. Okay, so this is going to sit right underneath that common insertion point. Those tendons in this bursa typically get aggravated when somebody falls into more of that valgus positioning. Okay, so adducted femur or internally rotated femur, they usually have weak lateral hip musculature. That's when you'll see this type of bursitis. Okay, we also have the IT band. Yep,
For the peasants, Ryan, you said weak ad or adductors?
ab,
Okay.
AB. Okay, IT band bursa. This is going to sit on the lateral side of the knee. It's going to be right over Gertie's tubercle, which is the insertion point for the IT band. Okay, so with that one, this is typically the cause of lateral knee pain when somebody has IT band issues. Okay, oftentimes that's going to occur due to overuse of the TFL and IT band. There is also the popliteal bursa. Okay, the popliteal space is basically just the entire back of the knee. Okay, and you will get this cyst back here that is called the Baker cyst. That's something that you'll see a lot in clinic, and that is basically just an inflammation of this popliteal bursa.
And that was called what?
Baker cyst. okay?
Yeah.
Usually this occurs due to tightness and overuse of the gastroc. Yep. And then last one here is the biceps femoris person. So this is going to sit right underneath the insertion point of the biceps femoris at the fibular head. Right? So of course that's going to become aggravated, inflamed with overuse or tightness of the biceps femoris. All right, last soft tissue structure, we have the Hoffa's fat pad. In this image, this is this yellow tissue that's sitting right underneath the patellar tendon. Okay, so you can see how it kind of takes up this whole space in the joint surface. Okay, this is really important to understand and often frequently missed in the clinic. Okay, especially when it comes to post-op patients. Okay, when somebody goes in for an arthroscopic knee surgery, they put their little tools and their cameras right through the fat pad in order to access the joint. Okay, and then they do the surgery. So let's say somebody has a meniscectomy or meniscal repair. They're going through that fat pad in order to access the meniscus. But then most people, once they get out, think, oh, this is meniscal repair. I'm going to treat it like a meniscal repair. And they forget that, well, this is tissue too, and that's also going to scar down. And a lot of times, if that is not immediately addressed, that will lead to a fat pad impingement. Okay? So somebody is going to be restricted in their full range of motion, especially in the extension, because this fat pad is impinging within the center of the joint. Okay? So in order to combat that, you have to do fat pad mobilizations. Okay, again, I'll teach you those things later, but basically just moving this tissue around. Just like you would do a patella mobilization or a patellar tendon mobilization, you're basically going to go on either side of the patellar tendon and mobilize that tissue as well. Okay? Overall, this does act as a protective cushioning for the joint. Yeah, Josh?
That was the medial meniscus surgery?
I was just using that as an example.
Oh.
That's not, it's not super relevant to this. Okay. Let's see. Yeah, so just make sure this is something that you know it exists and that you address after a knee surgery. Okay. All right, go ahead and take like a 10-minute break or so, and then come back and do the ligaments. Move on to the knee ligaments. Okay. These are important because between your ligaments and your muscles, these are primarily the things that hold the knee together. Okay. So we have two main sets of ligaments. We have the cruciate ligaments and the collateral ligaments. We're going to start with the cruciate ligaments first. These are your ACL and your PCL. Okay? The cruciate ligaments sit inside the joint capsule. So they are considered to be intracapsular ligaments. Okay? Okay, so ACL is right here, PCL is right here. So ACL is your anterior cruciate ligament. This is going to attach to the anterior surface of the tibia and then go up and across and then attach to the posterior surface of the lateral condyle of the femur. Okay. Versus your PCL, your posterior cruciate ligament, that is going to go from the posterior aspect of the tibia and then, sorry, my voice keeps cracking, and then run up and diagonally and attach to the more medial condyle of the femur. Okay? So, looking a little bit more closely at each one of these, again, right here we have your ACL, the anterior cruciate ligament. Okay, make sure you write this part down. The ACL prevents excessive anterior tibial translation on the femur. ACL is going to prevent anterior displacement of the tibia on the femur. Okay, or posterior displacement of the femur on the tibia. Okay, so it could be either or, they're saying the same thing, it's just a different point of reference. Okay, in the real world, when you hear people talk about it, they're always gonna reference the tibia in relation to the femur. Okay, but I want you to make sure you understand it both ways for your board exam. Okay, so, again, we're limiting excessive anterior displacement of the tibia. Okay, so your ACL is going to tighten during the extension, and it acts to prevent excessive hyperextension of the tibia. Okay, so again, it tightens during extension. Okay, so with that, if somebody has a big hyperextension moment, that is one of the potential mechanisms of injury for an ACL tear. Okay, so excessive hyperextension of the knee. Okay, the more common type that you're going to see is a valgus stress, especially on a planted foot. Okay, so the foot is planted, there's a lateral blow to the knee caves inward, that's gonna tear your ACL. Okay, there's two big stability tests that you guys will learn next summer for ACL integrity, but just for now, I want you to know the names. So you have an anterior drawer test, anterior drawer, and a Lockman.
Spell that one?
Lockman,
Or Lockman?
Lachman. Okay, so those two tests would assess the integrity of the ACL. Okay, and then we also have the PCL. Okay, so this is going to be the exact opposite. So it is going to prevent excessive posterior displacement of the tibia on the femur. Right? Or anterior displacement of the femur on the tibia. The PCL is going to tighten during knee flexion. Okay, so with that, your most common mechanism of injury here is called a dashboard injury. Okay, somebody has their knees up, knees go right into the dashboard. Okay, so you're getting that posterior displacement of the tibia on the femur. You'll also see it falling on a flexed knee. Okay, if you ever get a case question that has fall on a flexed knee on it, this should be the first thing that you think about. Okay?
But that
Yeah.
word, is that like crystals, applesauce, and you need to dip?
No,
But
no,
all
no.
I'm thinking about the legs of them, and like,
So like if you, like it depends on what seat you're in. If you're in a passenger seat and like you're sitting with your knees up like this and then that goes right into the dashboard. So the tibia is displacing posterior. Or if you're in the driver's seat and you're like for me, I have to be pumped up, you know, really high so I can see over the dashboard. And my knees would hit right where it's at. So it depends on your ride.
All the way forward.
Flexion. PCL tightens during knee flexion. Yeah.
Back for just 2 seconds.
I can't hear you. Can you talk up?
Can you go back for 2 seconds on the ACL? You said a planted foot was what again?
So if you have a planted foot and then there is a valgus force,
Okay.
that will tear the ACL. Alright, so next we have our collateral ligaments. ACL, PCL were cruciates. MCL, LCL are collateral ligaments. Okay? So these are located on the sides of the knee. Okay? MCL is medial, LCL is lateral. Alright? So these are going to provide more of the stability in the frontal plane. Okay? Your MCL in this picture right here, you can see that it's really long, it's a little bit flatter, it's more broad. Okay? And it is going to attach from the medial condyle of the femur to the medial condyle of the tibia. This is going to help to provide medial stability and again resist more of that valgus type force. Okay, so you're looking at more of that lateral to medial directed force. Okay, now your medial meniscus has fibers that actually go and have an attachment point on the MCL. Okay, so your MCL and your medial meniscus are linked, and oftentimes you're going to see both of them injured together because of that. Okay? In terms of your big, oh, did I say that for PCL? PCL, your big stability test is the posterior drawer.
Is the posterior what?
Drawer. Okay? For your MCL, this is going to be the valgus stress test. Yeah, so, listen guys, the question was how do people tear both their ACL and meniscus, is that what I said? So, it's gonna go back to that mechanism of injury, okay? You have, I don't think I have a slide on it, you have something called, oh I do, later on. You have something called the terrible triad, and this is where you have a tear of the ACL, MCL, and medial meniscus all simultaneously. And again, that's going to occur when you have that valgus force on a planted foot, because you're getting the medial collateral ligament, the ACL, you're stretching both of those ligaments in that same position, as well as attaching to those fibers from the medial meniscus. Does that make sense? So that's a very common injury that you'll see where all three of those structures are injured simultaneously by that foot planted valgus stress. Okay. All right, on the other side, we have the LCL. This is called the lateral collateral ligament. This one is going to be smaller. It is more cord-like, so it's not quite as broad as the MCL is. Okay? Unlike the MCL, you do not have an attachment to the lateral meniscus here. Okay, it is just the ligament, no attachment to the meniscus. So you don't frequently see as many lateral meniscal tears as you do medial because of that. Okay, so this is going to resist more varus type forces, so medial to lateral directed force. Okay, MCL and LCL will both also tighten during extension and slacken during flexion. Okay, let's pause there. I want a new partner. Go through each of these four ligaments and make sure you access. Okay, I don't know if I said that or not. And then somebody asked about injuries. So you can live a perfectly normal life with all of these ligaments torn. Okay? Just because they are torn does not mean that you have to have surgery. It is just going to depend on the severity of the injury, how your muscular support is, and what your everyday life looks like. Okay? So if you're somebody that is very active, very sports oriented, does a lot of, lateral cutting within your sport, you're not going to be able to do that if you're ACL or PCL deficient. Okay? So you would have to have those things repaired. If you're somebody who, just has to be able to walk in the grocery store, you don't need that extra support, so you're totally fine to not get those things repaired, okay? In addition, ACL is much more commonly injured than PCL. You don't see a ton of PCL injuries. You'll get them every now and then, but it is much less common compared to ACL. Okay? All right, so we're gonna move on to muscles. Same as before, I'm not gonna do the origins, insertions, actions, and nerves, but you guys need to know them. Okay, there's not as many muscles for this unit as a whole, so, and they should be, ones that you're already at least a little bit familiar with, so this part should be much easier for this section. Okay, so starting first with your quadricep, how many quadricep muscles do you have? 4. Okay, so rectus femoris, vastus lateralis, vastus medialis, vastus intermedius. Know that your rectus femoris is the only 2-joint muscle, okay, of your quadricep. Everything else is just 1 joint, okay? All 4 of these are going to come together and create the quadricep tendon that is superior to the patella. It is going to roll over top of the patella and then turn into the patellar tendon, and the patellar tendon is what inserts into the tibial tuberosity. Okay, does that make sense? Everybody good on that? Okay. All right, next we have hamstrings. How many hamstring muscles? 3. Okay, biceps femoris, semitendinosus, semimembranosus. Okay, remember here that your biceps femoris has 2 different heads. Okay, there is a long head and there is a short head. Pes anserine, what makes that up? Sergeant, which stands for?
Sartorius gracilis and semitendinosus.
Good. Sartorius gracilis, semitendinosus. This is your common insertion point for each of these 3 muscles. Popliteus, what did I say that does earlier? It unlocks the knee. Okay? So this is just a 1-joint muscle that is located in the popliteal space. And it sits deep to the 2 heads of the gastrum. Okay? So it is going to have more of an oblique type orientation, which is why it can contribute to that tibial internal rotation. Okay? Since it does span the knee, it also has an action to flex the knee as well. Okay? Then we have your gastroc and your soleus. So gastroc is going to be a 2-joint muscle. It crosses both at the knee and at the ankle, versus your soleus is just a 1-joint muscle, only crossing at the ankle. So we'll talk more about soleus next week. Okay? For your gastroc is a 2-joint muscle and also has 2 different heads. Okay? But also these are going to come together similar to the patellar tendon. These are going to form your Achilles tendon, and the Achilles tendon is what actually inserts into the calcaneus. For your gastroc, also, since it does cross the knee joint, it also works to flex the knee, okay, as well as plantar flex at the knee. Okay. Now, when you have a reversal of muscle contraction, it can also turn into a knee extensor in closed chain. Okay, so foot is planted, gastroc contracts, utilizing that reversal of muscle action concept, it is going to extend. Okay, so again, this can be really important for a spinal cord injury patient. Depending on the level, they might not have quadricep function, but they might have gastroc function. And they can use this concept in order to attain that standing position just through activation of their gastroc. Okay. All right, that was muscles in a nutshell. Next, we got the nerves. Okay, so same rules as before. Make sure you know where your nerves are starting, how they progress down the limb, what their branches are, and then what they innervate. Okay, so for your femoral nerve, what's the main muscle group femoral nerve is going to innervate? Exactly, your quadriceps. So if this nerve was injured, what is the main action that's going to be impaired? The extension. Okay, so that's how you need to be thinking about these nerves. not just from your cards, not just the muscles that they innervate, but if this nerve was damaged, if it was injured, what is that gonna look like clinically? What muscle action is going to be primarily impaired? Okay, so then I have the divisions listed here for the femoral nerve as well. So anterior femoral nerve, posterior femoral nerve, and the saphenous nerve.
Would that be in people's charts?
What?
Nerve damage, or not necessarily?
It depends on
Who they've seen,
who
right?
they've seen, what kind of testing they've had done. Like, a lot of times, people will, present to physical therapy first, and you are the ones that would detect a nerve injury and then send them for a referral to actually look at the nerve. And then also, like, is it a peripheral nerve issue? Is it a central nervous system issue? Like, there's just a lot of different variables, but you'll probably see it both ways.
And they can't really be fixed, right?
Nerves can regenerate, but they just regenerate very, very slowly. So again, it's gonna depend on what the injury was in the first place. Like, if it was truly just a peripheral nerve lesion, let's say somebody comes in and they, had a cyst that's compressing on the nerve, they have the cyst removed, now the nerve is free to move, they can still get full function back. It's just likely going to take a long time for the nerve to recover. Okay. All right, sciatic nerve. What's the main group that the sciatic nerve innervates? The hamstrings. Okay, so again, nerve is going to course through right here, and then you have two big branches. It's going to branch into the tibial nerve as well as the common peroneal nerve. Okay, so if we know the hamstrings are mostly the ones innervated by sciatic nerve, what are your primary actions that are likely going to be impaired? Hip extension, knee flexion. Okay. All right, common peroneal nerve. What is common peroneal nerve a branch of? I just said it. The sciatic nerve. Okay, so we know sciatic nerve, that's going to branch into common peroneal. Common peroneal is going to branch into the superficial peroneal and deep peroneal. Okay, these are also called fibular now as well. So you might hear that terminology: superficial fibular nerve, deep fibular nerve. Okay, so your common peroneal nerve is going to innervate the short head of the biceps femoris. Okay, so if that portion of the nerve was impaired, knee flexion would be impaired. Okay. All right, and then we have the tibial nerve. Okay, tibial nerve is going to innervate your popliteus, the gastroc, the plantaris muscles. Okay, so if that nerve is damaged, you're likely going to have deficiency in push-off when somebody's walking, doing, a calf raise, walking on their tiptoes, all of those types of actions. Tibial nerve is right here. So as it comes down, that's going to branch kind of way down here at the ankle into the medial and lateral plantar nerves, as well as the medial cervicocutaneous nerve. Okay, and then here is an image of your lower extremity sensory distribution. Okay, this image here is your peripheral nerves versus this image here is your dermatomes. Okay, so dermatomes meaning that this is the sensory distribution coming from those nerve roots in the spine. Okay, versus this image is your peripheral nerves. So you need to know them both. All right, we're going to run through a little bit of pathology. Again, we're not going to get super deep here, but I just want you guys to start becoming familiar with some of the most common things that you'll likely see. Okay, starting first with the patellar tendonitis. So this is also called jumper's knee. Okay, so here you're going to have inflammation, irritation, and tenderness right at the patellar tendon. So you can see how it's really red in this image right here. If you push on the inferior pole of the patella, that is where these individuals are going to be most sensitive. Okay, so it's right at that attachment point on the patella. Okay, so this obviously, depending on the name, this is going to be aggravated with jumping, with running, activities like that. Okay, you're going to see it mostly in basketball players, high jumpers, hurdlers, anyone Slaughter's disease. This is something that you're mostly gonna see in adolescents, so as they're growing. There's going to be an overuse in a traction type epiphysis injury right at the tibial tuberosity. So we know that this is where your patellar tendon comes in and attaches, and this area is going to get irritated. Oftentimes, when you see these individuals, the tibial tuberosity will also be much larger than you would typically see in somebody that doesn't have this as well. So you're getting that inflammation right of the growth plate in that area.
Just time makes it better? or-
Yes, yeah. So you're not gonna see that like in an adult. So they may have had a history of it and continue to have these problems, but that diagnosis in itself is just in that adolescent stage, and that's something that would just kind of go
You can't
away
do
over
anything
time.
about it.
So if somebody came in with it, you would still try to address muscle imbalances, because that's probably why it happened. So if their quad was too strong, or if it's too short, so they don't have very much mobility in the quad, that's what you're going to address in this situation. Patellofemoral pain syndrome. I really hate this term because it doesn't mean anything. Okay, this is a really big umbrella term that could mean 1,500 different things. Okay, so oftentimes if you get, especially younger individuals, if they go to the doctor, they complain of knee pain, this is the diagnosis that they're gonna come into physical therapy with, and then you're gonna have to figure out what is actually going on. Okay, so basically, this just means anterior knee pain. Okay, it could result from a lot of different things, all of those malalignments that we were talking about earlier. If they have an abnormal Q angle, if they have abnormal patellar positioning, oftentimes there's going to be muscular imbalances. So what's tight, and then same thing. It could go all the way up the chain or down the chain. Is something happening at the hip? Is something happening at the knee? Is something happening at the foot? Right. So again, for now, just know anterior knee pain. Okay. All right, chondromalacia of the patella. I think somebody mentioned this earlier. This is basically just a degeneration of the cartilage. Okay, you're most likely going to see it in this space here, right on the posterior aspect of the patella, in that interquadricular bridge. This is going to result in a lot of anterior knee pain. Okay, and you're going to get actual structural degeneration in this space. This is often caused by abnormal patellar tracking. Okay, so again, a lot of times with these individuals, there's going to be some sort of muscular and or structural imbalance. Okay, so your job is to be able to identify those things and address them as needed.
How do you feel about, I think what I was, this is years ago, but I think it was like the last 15 degrees can activate the medial fasting. And if it's pulling laterally, then doing like strength training for the medial fasting to pull it back. Do you think that's possible?
So you can't activate that in isolation. That's a common myth.
With it?
Yeah, and yeah, because you just can't. There's no way to actually do that.
Okay.
The most important thing with these individuals is going to be consideration of that patella force chart. So you might get better activation of the quadriceps in those deeper levels of flexion, but you're also putting much more compressive force through the knee, which is going to aggravate their symptoms even more as well. And so there has to be a little bit of a balance, and you have to work within the presentation of the patient. But I would advise more so strengthening, like starting in lower level positions, more in that open pack position, and then as they get stronger and more comfortable, then progressing to those deeper levels of function. Okay, terrible triad, we did mention this earlier. Okay, so again, in this situation, you're gonna end up with an ACL, MCL, and medial meniscal tear all simultaneously. This can occur with one single blow to the knee, usually with a valgus type stress. So lateral to medial directed force, especially when the foot is planted on the ground. misalignment syndrome. So this goes back to the positionings that we were talking about earlier and how they can all relate to each other, okay? So in this example, this one has an actual title where you have increased femoral anteversion. Then at the knee, you're gonna have that genu valgus where the knee is caving in. It's gonna result in increased tibial torsion, and then foot pronation, okay? So this is a very common pattern that you will see, okay? So again, just postural awareness, being able to identify those things in your patients and then address their impairments as a, okay? At the end of the day, no matter what somebody's diagnosis is, you are always going to identify their impairments and treat their impairments, okay? What muscles are tight? What muscles are weak? That should always be kind of thought process number one, and then you can build upon that as you go. Okay? So I know that was a lot of information, but a lot of it is also a little more conceptual. So if you can get down a lot of those beginning concepts, like I said, we don't have as many muscles for this section, so that part should be much easier. Sound good? All right, well, enjoy your lunch, and then we'll be back in the afternoon.